Hello and welcome to this week's episode of Future of XYZ. I'm really excited to be joined by Dr. Doreen Samelson. She is a clinical psychologist as well as the chief clinical officer at the Catalyte Foundation out in the Bay Area. Doreen, thank you very much for joining us on Future of XYZ today.
I'm happy to be here. Thank you.
Well, I mean, you're an expert in a lot of areas. You've worked in Kaiser Permanente's mental health care facilities and systems. You provide clinical leadership for behavioral health research. You've authored books, authored studies, obviously. You have about 30 plus years of experience in this field. And what we want to talk about today is the future of developmental disabilities. And what's so interesting is we started prepping this conversation way back when we first were introduced, is really why it matters and not just about the disabilities themselves, which sometimes are visible and sometimes are invisible, but really what does the future look like? That said, I always want to give guests an opportunity to define the topic at hand. So the first question is, how do we define in the context of this developmental disability?
Well, thank you, Lisa. That's a really good question. So developmental disabilities is really a group of conditions that we diagnose based on a set of criteria. But the most important kind of general thread throughout developmental disabilities is you have a child, a young child, who is not developing the way that we would expect a child to develop. So they're not developing typically. Often what we see are delays in language. So, normally we start to see even young babies communicate. We get those first words about 18 months, maybe 2 years. And if we have a child who has a developmental disability, what we often see is we don't see that language. Now, developmental disabilities as a group include things like intellectual disabilities. We used to call that mental retardation because that's an old term now. We call it an intellectual disability now. It also includes autism spectrum disorder, which is a very heterogeneous group. Some of those children also have intellectual disabilities along with their autism, and many do not. So it's a large group, and one of the things that we know about developmental disabilities is that they show up in childhood. So it's not something that somebody develops when they're an adult, for example.
But it usually carries through their lifetime.
Carries through their life, but we see it in early childhood. We can make the diagnosis in early childhood or maybe in school age. Sometimes occasionally we will, the diagnosis be made when in the teenage years, but almost always we see signs very early on. And if it's a severe developmental disability, we will see things, even a few months old, 6, 8 months old, we will start to see that things are not going the way that we would have expected them to go for typical development.
That would be things like fetal alcohol syndrome, Down syndrome, spina bifida.
All of those things. And what we see is that the child isn't making those milestones, right, when we would expect them. So we do have the genetic disorders, something like Down syndrome would be a good example. We also have things if a child was exposed, as you mentioned, fetal alcohol syndrome to alcohol during pregnancy or some other, teratogens during pregnancy, that can happen. Sometimes we have a birth injury, right? We have a lack of oxygen during birth. That could be an issue. So it's a whole group of conditions. And because it's a large group, that means there's a lot of kids who actually do fall under the umbrella of developmental disabilities.
It's really comprehensive. And I think, the organization that you currently work for, Catalyte, you claim to be a provider of person-centered care, right? And this is advancing access to the critical services that are necessary, but also obviously and in support of people with disabilities, but also for their families and advocacy and things like this. But in terms of that person-centered care, what does this actually look like?
Well, one size never fits all, right? So when we look at person-centered care, we're really looking at the child. It could be youth or adults. We have services for adults as well. And we also, of course, want to look at their environment. We want to look at their family. So sometimes we say person and family-centered care because we want to get that family in there for sure. But we really want to make sure that we are providing the services or the treatment that really fits that child, youth, or adult and the family. And so it's specific to them, so that we're not saying, everybody with a developmental disability gets X. That doesn't make any sense, of course, right? We want to really tailor our services, or if we're doing treatment like behavioral health treatment, we want to tailor it to that child and that family.
Which makes a lot of sense. I mean, I don't know if we had talked about this in any of our previous conversations, but my younger sister is on the autistic spectrum and was diagnosed extremely late because the research wasn't quite there yet, and she was quote unquote very high functioning. The intervention that didn't ever happen has had a material impact on her life as well as the whole family, of course. And I know you yourself also are the parent of a developmentally disabled adult now. How has that experience shaped you were a clinical psychologist before that. So how has that shaped your understanding of how we treat and address and intervene in kind of the disability world?
Mm-hmm. Well, thank you. That's such a great question. I think I've learned so much from my son. I mean, my son has been my greatest teacher. And because my son has minimal language connected to his intellectual disability, I really learned a lot about communication and language and the role that communication plays, and how we can really work with somebody like my son to help them communicate in all kinds of different ways. Again, it's not like one way is not the right way. So for my son, he uses some signs. He uses gestures. I always say you can get a lot done with pointing. If you have a child who has a minimal language, teaching them to point is often one of the first things that we do, because now that allows some self-determination. So the parent can hold up juice and milk and the child can point to which one they want. And that seems like a little thing, but if you have a child or a youth and adult who's really has minimal language abilities, their ability to just say what they want to drink or what they like to eat, these kinds of basic things really improve self-determination. And we know that self-determination for the person with a developmental disability and for their family, options and self-determination, family self-determination, really rolls up to well-being. And so we can improve well-being by improving communication and improving self-determination.
It makes sense. I mean, I think you have a very clear passion for that self-determination piece of things. And as you mentioned, it's not only for the developmentally disabled person, child, or otherwise, but also for that family. Inclusion is another piece of this, right? And if you can't communicate in any way, you're kind of excluded from the world at large. Is that what you mean by inclusion of people with developmental disability?
Yeah, inclusion is something that we hear about a lot. And of course, inclusion is important, but it's also important for the person to decide where they want to be included. So, sometimes we say, well, just everybody needs to be included in everything. Well, we have some youth, for example, with autism, autistic youth, some without intellectual disability who are quite bright and say, you know what, I'm not interested in those social things. That's not my thing, and I don't want to do that. So we want to give people options and choices, and that's where the self-determination comes in. On the other hand, we want to make sure that people are able to be included in the things that they want to do, and they're able to get jobs and go to school and do all those kinds of things. So I think where we've gotten from where I started many, many years ago in the field is that we really recognize that we need to have a lot of options for people. And for some people, and autism is a good example, having time by themselves, not necessarily being included in social situations when they don't want to be, is very important for their well-being or quality of life. My son happens to be quite social and he likes to be included. So, for him, inclusion is really important, but we need to really make sure that we're providing the person what it is they really need.
Well, it makes a lot of sense. And I mean, obviously, there are professional caregivers. There are psychologists, there are doctors, there are medical researchers. There are all sorts of people involved, also policymakers, executives at the healthcare companies, the pharma companies, et cetera, who are major players in this. But what is, and I think you have a real passion for this, and Catalyte, I think, enables this, but what is the role of the parent or another caregiver in mediating the care for someone who can't necessarily be an advocate for themselves?
Well, that's another good question. And one of the things that we really worked on is having options, parent or caregiver mediated treatment options. So what we found, particularly for our younger children or youth who may have an intellectual disability along with autism, is that empowering the parent and training the parent to actually do the direct intervention works very, very well for a lot of families. And it also gives that parent a way to really improve their communication and their relationship with their child, which is often equally important. So when you think about treatment, you can have a professional, often as a paraprofessional, going in the home and working with the child, but you could also train the parent to work directly with a child. It could also be a grandparent. Don't forget grandparents. It could be an aunt or some other person in the family that is going to actually be trained in the intervention for that particular child. And you can obviously have a combination of things where you have, a professional or a paraprofessional involved, you have the parent caregiver involved. And again, depending on how old the child is, depending on what it is we're trying to address, whether we're trying to improve communication or whether we're trying to decrease behaviors that are problematic, which we do see a lot in our population. It, sort of depends again on the family and the person, what's the best fit for them. But I think it used to be that we sort of said, if you have a child with a developmental disability, you sort of hand them over to the professionals. And that we know is a mistake. Parents, they know their child best, they understand their child best, and working with a parent is really a great way to see progress in a child.
I love that. And it makes a lot of sense from firsthand experience as well. There's always in every conversation these days a whole lot of talk about technology and the role that technology plays. And since we're especially looking to the future of developmental disabilities, what are some of the technologies that you see emerging and that, let's say 5 to 10 years from now are going to be really, really important for this, conversation of developmental disability?
Yeah, there's so many. I want to start out talking about a technology that's not that new, and that is noise-canceling headphones. A lot of our kids with developmental disabilities, both those with autism and those with intellectual disabilities, are very sensitive to sensations, and they can be very sensitive to a lot of noise and things going on. And giving a child a really good pair of noise-canceling headphones can really make a big difference to them. And that's a technology that wasn't around, actually, even 25 years ago, but they're readily available now. So sometimes it's smaller technologies like that, and even technologies that are a little bit older that are very helpful. There are a lot of emerging technologies around training and teaching. We do have to be very careful with young children, in particular with screen time, because we know that even for typically developing children without a developmental disability, a lot of screen time actually affects their brain, and it's not good and interesting.
Ours too.
And ours too, right? Yeah, we're on the screen too much. But particularly for young children where their brain is developing. So we want to be very careful about screen time. One of the things that we've talked about at Catalyte, we've presented on in some of our conferences, is a wearable, where the person is wearing something that is able to alert a caregiver when they might be in distress. There's also wearables that might help for someone who has dangerous elopement, where, we're worried about a child being lost. So, finding them like GPS. And then there's lots of things that are coming out around teaching technologies. There are a few gaps, though, and I'm going to just mention one because I'm hoping someone will be listening to this and they would help with this one particular gap. And that is, we don't have enough games, like computer games, for someone like my son that doesn't look like a baby game because he doesn't want to play something that a little kid would play, but he can't really understand, even the simple computer games that are out there. But he has an iPad and he wants to play a game. And I'm really hoping that people will start to develop, some of those leisure activities for people like my son who are adults. Or teenagers, and they can have the gaming experience as well. So there's lots of room for lots of smart people in tech to develop new things, for sure.
I love that, Doreen, and hopefully someone is listening because that's such a huge, gaming is a multi-billion-dollar industry. The fact that this isn't being addressed is unfortunate. But I think it also leads to a natural question of like, what are some of the barriers to providing proper treatment and service, and who are the players who can and will be addressing this going forward?
Well, there's a number of barriers. Coverage, insurance coverage can sometimes still be a barrier, even with the Affordable Care Act. We still have in some states, especially those that did not expand Medicaid, where we don't have good insurance coverage for some of our families. I'm in California and Hawaii. We are in both those states, and we have better Affordable Care Act coverage in those states. But there's plenty of states that don't. And another thing I think is just people not understanding and not realizing that when they see if a child is not developing the way we would expect, it's time to go and get an appointment with a pediatrician and say, he's not talking yet. And usually, the children really have quite a few words by age 3. And we would really be worried if a child is not having some words by age 3, and get that early intervention. We know early intervention is very effective. And one of the other problems that we see is just people being in locations where they're out in more rural areas, and they may not be close enough to some place to even go and seek an evaluation to get a diagnosis. And so that can be a barrier. Telehealth has really helped. Since the pandemic, we've really been able to expand telehealth. We did very little telehealth before the pandemic. We do a lot of telehealth now. And there's a lot of good research that's come out showing that we can do a lot with telehealth. So
Telehealth is interesting.
Yeah. There's just a lot of different things that can be barriers in different areas of the country and in different, rural versus urban areas. And that kind of thing. There are some cultural barriers sometimes where people are not, feel like they really can't bring up a problem. Sometimes that happens, although I think we're seeing that less.
Yeah.
But we still are missing kids that we need to be addressing.
And in terms of kind of the conversation, everything is local, and often this is just a family specific experience. Unfortunately, it's very isolating. Sometimes it's very hard. The money that you need to access care, to navigate the healthcare system, especially in this country. But is there anything happening at a policy level, either locally, state, federally, or better yet, even like internationally, that's addressing any of the future of developmental disability kind of challenges?
Yes, I think there are a few things. Now, one of the things that happened with autism is that now all 50 states mandate private insurance coverage for autism services. And that was something a lot of parents and a lot of clinicians fought for. And now for a few years now, we've had all 50 states. The laws may differ a little bit state to state, but they're all covered. Now what California did was they expanded that. So it's not just autism, it will be any developmental disability, right? I like to see the other states follow suit with that, because what's happened is if you have a child with Down syndrome and somebody else has a child with autism, it may be that the child with autism is getting more services through their insurance company than the child with Down syndrome, which doesn't make any sense, of course. So hopefully, some of the other states will follow what California has done and expand the health insurance coverage, which I think is very important. There are a number of international organizations. We were able to present in Sweden at an international conference this year. We're hoping to do that again next year and present our research. So there's some international organizations. And what's really interesting about some of the international work is that we find, again, training parents. So there was a very nice presentation in Sweden by researchers from India, rural India areas, where they were training parents, just like we're doing in California. I'm not in a rural area. I'm in an urban area, and I'm training parents. And they were training parents in this very rural area in India and getting great results again by training the parents. And so if we can figure out ways to reach people, we can use family members to do that. I think that's one of the things that's really going to help us going forward.
Yeah, that makes enormous sense. And I appreciate that kind of like quick global overview, because although the challenges are different, they're also universal.
That's right.
Especially when dealing with developmental disabilities specifically, right?
Yeah.
I mean, it manifests in the same way when whatever your language, color, race, ethnicity, gender, or anything else. So I think that's quite interesting, especially when we think about inclusion as well.
Yeah.
As we think about wrapping up, we have a couple more questions. One of the most important ones, I think, is how to measure outcomes, because in a lot of these developmental disabilities, as you said, the issue manifests in childhood at some level, but it carries forward, through the future. And I think about my own sister, who, again, high functioning, but doesn't function within normal society in any way, shape, or form. I think about, had she been diagnosed younger, what outcomes could we have hoped for, and how would we have measured success along the way? What is your take on that? And I know Catalyte has some strong perspective on this also.
Yeah, we do actually. There's a lot of different outcome measures. And, we all look at goal attainment, for example. I don't think you're going to look at any program that doesn't have goal attainment. And we certainly look at goal attainment. And then, there's other things we want to look at. We look at sleep. Sleep is very, very important to improve sleep. So there's a lot of different things you can look at. But here's where we finally landed. All of that needs to roll up to well-being or quality of life. So we've developed some well-being scales as a result, because what we said to ourselves is that, okay, so they met the goal or they didn't meet the goal, or, this is a little bit better, that's a little bit better. But is their well-being improved? And is the family's well-being improved? And one of the things that we've learned is that you don't have to be doing things the way everybody else does them in order to have well-being. So I'll give an example about my son. My son can't count money. And he used to, when he was younger, we had the IEP, and we had the goal of counting money every year, counting money. And it's just like, he's never going to count money. He never learned to count money. But here's what we've realized. What he wants to do is buy his own coffee. Well, you can buy a cup of coffee anywhere if you have a $20 bill in your wallet, right? And it doesn't matter, even a fancy coffee you could buy for at least less than $20, at least so far anyway. And so my son's well-being is really, most places, my son's well-being is really about being able to buy his own coffee. It's not about counting money. So if we think about well-being, then we think, well, counting money for this person is not the right goal, really. What is the goal? And for your sister, what would improve her well-being? She doesn't have to be like everybody else. She can be herself, but what things would actually improve her well-being? And that's kind of the direction that we're really going now at Catalyte. We've got a lot of different outcome measures, and it's very important. We look at dangerous behaviors and decreasing dangerous behaviors and things like that. But of course, if we do decrease dangerous behaviors, we're improving well-being. But we want to see everything roll up to well-being now.
Again, you had mentioned that previously, and I really like the idea of well-being as like the goal, and well-being's bandied about in lots of different forms these days. And in this context, it actually really means something very, very profound. So my last question, I think about Catalyte's mission, which is to support individuals with developmental disabilities as they embark on their own journey by removing barriers and biases to create a more inclusive world, one that reflects and celebrates the unique differences of everyone. Again, we talk about this. That's quite a big, bold, audacious goal, given the thing, which is, of course, what a great mission statement does. If we look ahead, and this is always the last question on Future of XYZ, 10 to 20 years in the future, what is your greatest hope for the future of developmental disability?
Well, my greatest hope, I think, is that we will have options that support families and children and adults, and that they will be available to everyone. And we didn't talk about the intersectionality between, say, race and developmental disabilities, but that's an issue, right? So some of our underrepresented groups don't always get the same services that someone who's white does, for example. So really paying attention to that and making sure that there are those options for services that are the right fit for that person and that family. And the parents don't have to, go searching all over the place and begging for them, right? But that we will be there because we want people to be able to have their own path, and everybody's path is different, and we think that's okay.
Yeah, I love that. Well, Dr. Doreen Samelson, thank you very much for joining us on Future of XYZ today. For everyone watching and listening, you can learn more about Catalyte and this topic at catalyte.org. You also, if you aren't already following Future of XYZ on social media, please find us at Future of XYZ on Instagram. You can visit future-of.xyz to learn more about the program, to nominate yourself or someone else you know as a guest, or just generally to access any of the podcast channels. Anywhere you get your favorite podcast is good. And you can visit ripbs.org/XYZ to access the videos through our presenting partner, Rhode Island PBS. Thank you again, Doreen, for joining us. And for everyone watching and listening, we will see you again in 2 weeks.